Okay, thanks, Noreen, and thank you everyone for inviting me. So today I wanted to talk about metastatic prostate cancer and how the treatment has changed. And it is changing. It's one of the reasons that people come into oncology is that it is a dynamic environment. And that is also true of prostate cancer for certain. And one of the themes that I suppose I'll be talking about over the next little while is the treatments that traditionally we have used in, very advanced disease are now becoming more utilized earlier on in the disease process. And that is resulting in better outcomes for patients, which is great news. Unfortunately, people with metastatic disease, as I'm sure you all know, will still end up succumbing to their disease eventually, and developing symptoms. But in the interim, there's a lot more that we can do for them in terms of active therapies. So this is the treatment landscape, and I suppose traditionally, when I started oncology, it seems like a long time ago now, we would get involved in what's called the castrate-resistant setting. So basically, the initial treatment for metastatic or indeed locally advanced prostate cancer is androgen deprivation therapy, as it's called, typically given by injection to suppress testosterone production in the testes. And usually once it's begun for patients with metastatic disease, it is continued for the rest of their lives. It's a question I get asked a lot, is whether, people who have progression of disease, do they continue on their injection? And the dogma over many years has been yes, until it no longer makes sense, I suppose, for them to do so. So androgen deprivation therapy, when cancer starts to grow despite being on androgen deprivation therapy, we call that castrate-resistant disease. And when I started off in oncology, basically that's where we came in, and we didn't really have a lot of things that we could offer patients at that point. And we had chemotherapy, docetaxel, and not much else. Thankfully, that is changing. As you can see from this slide, we now have this Cassodex, which has been around for a long time. That was the first generation anti-androgen. So if you go on androgen deprivation therapy, that takes away about 90% of the testosterone in the system. It doesn't take away 100%. And what happens is that the remaining tumor cells become very sensitive to low levels of testosterone. And that testosterone is not generally produced in the testes, but it can be produced in the adrenal gland or in the fat stores. So, and for some time then, we have been used to treating those low levels of androgen with drugs like bicalutamide or Cassodex, which sits on the surface of the cell and stops the androgens in the system from acting. So thankfully, we have stronger and better drugs than bicalutamide now. We have one called Enzolutamide, which is so-called novel anti-androgen, and it works in a similar way on the androgen receptor. We also have another novel anti-androgen called abiraterone. We'll talk about those in a minute. Other agents we have now are radium-223. We have Carb Inhibitors. We have still have docetaxel, and now we have cabazitaxel. So I suppose a lot of it is about where and when we use these individual treatments. Immunotherapy, patients ask a lot about, and probably at the moment I would say it doesn't have a defined role in prostate cancer. There is some activity, but probably in between 10 and 20% range. So not a proven treatment for metastatic prostate cancer at the present time. So I was saying that when I started off, we would see these patients here, metastatic castrate-resistant with metastatic disease. We give docetaxel. After that, we weren't really sure what to do. But what has happened over time is that these treatments that I'll talk about have started to be used much earlier in the disease process. So whether you present with metastatic disease, and about 20% of patients who are diagnosed with prostate cancer either present with what's called high-risk localized disease or metastatic disease. And we now know that and our traditional management for those patients is put them on androgen deprivation therapy and bring them back to typically to the urology clinic every 6 months until their PSA starts to rise, at which point they'd be referred on. That's changed now. So what we do now is we ask to see those patients much earlier in the disease process, basically as soon as they're diagnosed. And we start to use some of these treatments at that point in the disease process. And the result of that is that you get much longer disease control than you used to. So one of the studies that is going to be presented this year for people who were diagnosed with metastatic disease and go on hormone treatment, androgen deprivation therapy, with or without other treatments. The standard, you would have said, how long would someone be on androgen deprivation therapy before they start to progress? And the answer to that was about 18 months. Now, and this latest study is going to be presented this year, the average time till someone needs another treatment is 4.5 years. So that has actually fundamentally changed the outlook for these patients who are diagnosed with metastatic disease. And that's one good thing, and a thing that I always try to emphasize to my patients, that people who are diagnosed with metastatic disease, obviously they're devastated at the diagnosis and they may be in pain from bone metastasis, which is a hallmark of prostate cancer. But in fact, the median survival for someone who's diagnosed with metastatic disease de novo is in the order of 5 years. And for many patients, it's longer than that. So I usually say to them, your survival is going to be multiple years, and how many years depends on how well the treatments that we're going to give you work. So certainly better than pancreas cancer, which is another cancer that I see a lot of. So this is going back to the old days of Taxotere, and you can see a small benefit. This is Taxotere in the castrate-resistant setting. Small benefit, approximately a couple of months of additional survival for significant toxicity. And really, it was a valid question to ask at that point, was it really worthwhile? And the answer to that is, for a lot of patients it is, but for some patients it isn't. And this is what I was referring to about how as you reduce the testosterone levels, the tumor becomes very sensitive to very low levels of testosterone that are in the system still. And then your next line of treatment are going to be aimed at reducing those low levels even further. Yeah, that's just the same point again. And there are more than two now. This is an older slide. There's abiraterone, and there's enzalutamide, and now there's darolutamide, and there's apalutamide. And so there's a number of these drugs out there now, and difficult to choose between them sometimes, I would have thought. We'll start with abiraterone. This works on the adrenal gland. So I said, if after androgen deprivation therapy, patients, this is Zytiga, you'll see a lot of the patients that, especially the elderly ones, will be on this. So a lot of the remaining testosterone after ADT is produced in the adrenal gland. This works in the adrenal gland, and it inhibits the pathway in the adrenal through which the testosterone is produced. Now, it diverts those precursors down other pathways, and it can actually lead to increased levels of fludrocortisone. And as a result, one of the main side effects of abiraterone is it can cause fluid retention, and it can cause hypertension. It can increase risk of cardiac events. So you have to be careful when you're starting patients on this drug. And it also has to be prescribed with 5 milligrams of prednisolone. It used to be 10, and now it's 5. And again, that 5 milligrams of prednisolone is aimed at counteracting some of those side effects of the abiraterone and how it diverts production of enzymes down an alternative pathway. I have to say that for most patients, if they don't have heart failure issues, this is a very well tolerated drug. it doesn't it causes fatigue like all hormonal agents do. But other than that, if you don't get the fluid retention, hypertension type of things, then it tends to be very well tolerated. And a lot of the patients, once they get onto it, will be on it for a significant period of time. In the studies that were done using abiraterone, basically you get about, in the castrate-resistant setting, which is where it started being used, you get about between 12 and 18 months of PSA reduction and disease control from it. And at that point, the cancer generally starts to progress again. But generally that time will be associated with quite a good quality of life. And people are able to live their lives, hopefully, in a reasonably good way. This is just how it works. It's a 1720 lyase inhibitor. It reduces testosterone as well as estrogens. And this is the pivotal study. I won't go through that except to say that, as you can see on the study, the median duration on treatment was about 1.5 years. So, and generally good quality of life for that time. And what generally happens then is you start off using these drugs in the castrate-resistant post-chemotherapy setting. Then you bring them back and you say, let's give it before chemotherapy. And the benefit is bigger if you give it before chemotherapy. So for most patients, we would give one of these novel anti-androgens before we would give chemotherapy nowadays. And it's only when they begin to progress, despite being on a novel anti-androgen, that you would think about giving something else. There are slight exceptions to those rules. Generally, it's people with younger men with very aggressive disease pattern. But for the most patients, they would get a novel anti-androgen as their first treatment before they would get chemotherapy. That's the side effects which I mentioned to you. Fatigue is always there with any hormonal treatment. Fluid retention, obviously much more significant. Then it can interfere with the potassium and sodium levels, hypertension, and cardiac disorders all increased. It can affect your liver function. That generally tends to happen early in the disease process, so we monitor that carefully. If it hasn't happened within 3 months, it's probably not going to happen. So this is enzalutamide, which works in a different way. I was saying to you earlier, it's related to bicalutamide in its structure, but it has slight differences. So, but it works on the cell surface. It stops the androgen receptor from binding and from internalizing and causing tumor growth. It's better than bicalutamide. This is a similar study, the one I just showed you with the abiraterone, and the benefits are similar with enzalutamide to what they are with abiraterone. Now, enzalutamide is called Xtandi. It, for the most part, is well tolerated. It doesn't cause fluid retention. It can increase the risk of cardiac disorders, but then again, most treatments, any hormone treatment, increases the risk of cardiac disorders because they alter your biochemical environment. They increase your blood pressure often. They can affect your cholesterol. They can affect your ability to take exercise. They increase the risk of obesity. They increase the risk of diabetes. So they have many, many effects on the cardiovascular system. So we generally would try to encourage all our patients who are on any of these treatments to take exercise, regular exercise. We have physiotherapists programs, which we would, for the ones who are able, to encourage them to do that. The nice thing about enzalutamide versus abiraterone or Xtandi versus Zytiga is that you don't need to give steroids with it. It's a tablet once a day. It's 4 tablets once a day, actually. The problem being with it is because it can cross the blood-brain barrier, it can affect concentration. So it causes fatigue. It can affect your concentration. I've had one patient who crashed his car on it. I've had a number of people who've complained of loss of memory on it. A few people who've had problems with sleeping. Generally, as a result, I try to reserve this for my younger patients who are probably a bit fitter. It are those patients where you don't want to be giving them steroids, like maybe your diabetic patients. It is a good drug. I would regard it as about equally efficacious to Zytiga. There is one rare but significant complication, and that is the risk of seizures. I've had one patient who got seizure from Enzolutamide. He'd never had a seizure before. So obviously that's a very significant, he was taken in by ambulance to Tala. So obviously that's a very significant side effect, and rare, but obviously very serious. So you have to counsel the patient before you begin the drug. Seizures there, as you can see on that slide, it's a low incidence, but it definitely does happen. So we have two good hormonal options. And I would say the problem being, even though their mechanism of action is similar, or is different, excuse me, there seems to be cross-resistance between them. So you can't really, well, you can, but it doesn't work. You can't switch from one to the other when the first one stops working, because that tends not to be a strategy that's of benefit. So basically, what you do is you choose your one you're going to use for a given patient, and you try them with that one. Obviously, if there's a side effect, you might modify to the other one, but generally you would keep going with that until the disease starts to progress. And then you would probably not have an option to switch to the other one because the response rate is low. You're probably wasting your time there. And this is one of the difficult issues that we get to at this point, is we get to what to do in patients who've been very well, usually on their hormonal agents, their anti-deprivation therapy. They've been very well, and they've very minimal toxicity probably from their previous treatment. And now their disease is beginning to progress, and they're saying, "What's now, doctor? Have you another tablet for me?" And they actually, no, at the moment we don't. And the next line of treatment is probably chemotherapy, which is, for many patients can be a step too far, and for most patients is associated with significant toxicity. There are two drugs currently in use: docetaxel, which I showed you earlier, which is, the standard drug that's been in use since that study that I showed you was 2004. And then cabazitaxel, which was published in 2010. Similar type of drug mechanism. It works on the microtubules. It is better tolerated probably than docetaxel. Has to be given with growth factors, because it does cause, the main side effect is febrile neutropenia, which in these men with bone marrow suppression from tumor infiltration can be very serious. So what else has happened? So we have options. We have chemotherapy. You can go back to docetaxel again. Sometimes you can switch from docetaxel to cabazitaxel. Radium-223. It's in the same. The reason I'm showing you this slide is it's in the same column of the periodic table of the elements as calcium, and that's why it when you give it, it goes to bone. And it's linked to alpha particles of radiation. So you give it by injection, it goes to the bone where it mimics calcium, and it releases its payload, in other words, the radiation, into the bone marrow, which is where the tumor is, often in prostate cancer. So it naturally, because the radium is being taken up into the bone, similar to calcium would be, it naturally goes to where the bone is growing or where the tumors are. And it releases the radiation there. It only works in the bone, which is the problem with it. Now, the majority of patients with metastatic prostate cancer have bone disease, not all. But if you have visceral disease, as in lung or liver metastases, they tend to be late on in the disease process that they occur. This is not a suitable treatment for you. And if you have significant nodal disease in the pelvis, it's just where you usually see it, then this is not the treatment for you either. Other than that, it's a very good treatment in that the toxicity is low, you get fatigue, but not a lot else. The one thing, it's excreted via the bowel, and it's given once a month for 6 months. The one thing that patients don't like about it is that it doesn't reduce your PSA. So the patients who have been on these treatment, it does improve your survival, but it doesn't reduce your PSA. And it is good for pain. So people who've had bone metastasis on previous radiation, who know all about the pain issues that people have, this is a good treatment for them. Unfortunately, that when they get to this stage of their illness, most patients are, basically living by their PSA. And the problem with this treatment is it doesn't reduce your PSA. So a lot of them are discouraged because of that. At the moment, this is only allowed to be used after all other treatment options have failed. Now, I think that will change as time goes on. But at the moment, that is the license that is allowed for it. So if you have to have had chemotherapy first, or else you're deemed not to be a candidate for chemotherapy. And I think for many patients, that's probably too late. We probably need to be using this treatment earlier in the disease process. But it is an effective treatment and generally is given by the radiation oncologist. So it requires a good deal of interaction between medical and radiation oncologists. The adverse effects, it can cause anemia, it can cause anything in your bone marrow, of course, and then bone pain. Other than that, generally well tolerated. So the other thing that's happening, there's two other things that I want to just briefly talk about. One thing that is happening is the arrival of PSMA diagnostics, but also PSMA therapeutics. So PSA is, obviously we know what PSA is. PSMA, prostate-specific membrane antigen, is also associated with prostate cancer. And there are now, it is now being used as an adjunct for PET scan diagnostics. So basically, I had a case, this is a case I presented to the registrars there recently of a 54-year-old man who presented with PSA of 9 and a high-grade Gleason score cancer, and he had an equivocal scan on his bone scan. So he definitely had locally advanced disease and a small bone lesion, which we weren't sure whether it was metastatic. Well, the way to find out if it is can you do a PSMA scan? And in fact, it was metastatic. The difficulty that we have with is access. At the moment, there's only one place in Ireland that does PSMA scans, and that is St. James's. They have a significant delay in doing them, between 6 months and a year. It's now being recommended that anyone who's diagnosed with high-risk prostate cancer has a PSMA scan because it's much more sensitive, as you can see here, at picking up metastatic disease, and it changes the management in about a quarter of patients. So your plan was for surgery, well now it's not because you have a metastatic lesion. So it's better than conventional imaging, CT and bone scan. We need access to it. But for the purpose of today, what is now being done, and this is pioneered in Australia, but is also now beginning to filter into other countries, is PSMA-directed therapy. So in other words, in the same way as I said, radiation was attached to radium particles. Now what is being happened is payload radiation typically is being attached to PSMA particles, and the PSMA is then being injected into patients. It goes directly to where the tumor is, and unlike the radium, it can go to visceral metastasis as well as bone, and it drops its payload there and affects the cancer. Again, very effective and relatively low toxicity. So at the moment, not available in Ireland. The treatment is not available in Ireland. It won't be too long before it is, because there's a number of pharmaceutical companies developing it. There's probably 3 or 4 being developed. And I think it'll make a major change in how we manage patients with metastatic disease, and probably will supplant chemotherapy and will then be used before chemotherapy, I would have thought, for many patients in the future. So that's very exciting for the future of prostate cancer treatment, and it's not that far away. What I was saying to you at the beginning, I'm conscious of the time, is that what the UK has to be is that many of these treatments that we used to use later on in the disease process are now being used earlier on. And the UK has done this very large studies called Stampede, where they've basically accrued all their newly diagnosed metastatic patients to this study, and they've done a number of different arms. And they've shown that we should be using these treatments up front in the disease process rather than later. Interesting, one thing that they showed that was not beneficial was when you're diagnosed with bone metastasis and you're still in what's called the castrate-sensitive setting, there's no benefit to Zometa at that point. It's only when you become castrate-resistant that the Zometa can prevent skeletal-related events. So docetaxel we now use up front, or sometimes we use abiraterone, or sometimes we use enzalutamide, depending on the patient. In the future, it may well be that we end up using chemotherapy and a novel anti-androgen together right at the beginning of the disease process. And I would suspect that those will also come back into people who are diagnosed with high-risk disease as well. So this is probably the beginning of a complete change in how we manage prostate cancer. So one last thing I wanted to talk about is we now are beginning to understand that there are different drivers to prostate cancer. Some is genetic, of course. Some is familial, but we don't understand what gene is causing it. And then some of it is just, you know, bad luck or environment. But one genetic cause, of course, is BRCA. BRCA2 typically in prostate cancer. It's between 5 and 10% of all prostate cancers. And those cancers tend to be more aggressive. They tend to behave, they don't respond as well to the traditional treatments. And they tend to go through they present more with metastatic disease, they don't respond well, chemotherapy or hormone treatments. So like in other diseases like breast cancer, there is now what's called Carb Inhibitors. These BRCA obviously is normally involved in DNA repair. And when you have a faulty BRCA gene, your DNA is not repaired appropriately, and that's one of the reasons you get cancer. But the PARP inhibitors take advantage of that. So cancer cells obviously are cycling more rapidly than normal cells, and the PARP inhibitors will cause DNA damage, which can't be fixed by the tumor cells because they have this faulty mechanism in them. So the idea then is to damage the cancer cells more so than you would normal cells. And there are a number of PARP inhibitors out there, so they increase the number of double-strand DNA breaks, which cannot be repaired. They're generally tablets. We now should be testing all our patients, and that's a challenge for us because it's not in place yet, for germline BRCA and probably also for development of BRCA. Germline is you're born with it. Somatic means you developed it over time. That can also happen too in prostate cancer. So we need to be testing all our patients because these drugs are oral. They're generally well tolerated apart from some nausea, certainly better tolerated than chemotherapy. We've done a number of studies with them here in Ireland and elsewhere, and they do work. So they have significant anti-tumor activity. The longest person I have on one is on a trial. He's been on with about 3 years. So significant improvement in our treatment options for patients. The other thing is when you do genomic testing, sometimes you'll pick up other leads that you can follow in patients with advanced disease. So that we're routinely doing that now as part of our the clinical trial that's open. So I think that's mostly what I wanted to say. Basically, that's a run through the different options. The key is that those things are improving. We're having new options available to us. A lot of it now is about picking the right treatment for the right patient and picking the sequence correctly. People are definitely living longer and we have more options for them. But ultimately, we will still obviously always need the close collaboration of our colleagues in palliative care because the nature of prostate cancer is multiple bone metastases. They run into problems with pain, fractures, and we need your support. So thank you very much.